Good evening, everyone. My name is Rosalind Pearce. I'm Executive Director of Healthwatch Oxfordshire. I'm pleased to welcome you to this evening's discussion and presentation about the Community Services Strategy, Principles and Public Engagement event. Before we move into questions, there's a bit of housekeeping that I'd like to take us through. That is that this meeting is virtual and open to anyone to attend. You can post comments and questions in the comment box during the meeting, and we will do our best to respond before the end. After the meeting, we will publish a recording of the meeting, and we'll also pick up any unanswered questions in a separate Q&A question and answer list. We would also like you to complete the short questionnaire on the Talking Health engagement portal, and the details about this will be at the end of the presentations. I'm now going to just take you quickly through how you can post questions. Just to be clear that the questions are all written at this event, so there's no opportunity for you to actually speak. But if you look on your screens, you will see that there's a Q&A function that is displayed, and you can hide and unhide it by clicking on the speech bubble with a question mark. Can you see it's a sort of double speech bubble at the top in the middle of the screen? If your Q&A function is hidden, click on the speech bubble with the question mark, and that will bring your the opportunity for you to write questions out, which will then be published. Okay, that's the sort of the end of the sort of housekeeping. Normally, if we were in a room together, I'd be telling you about fire exits and all that sort of thing. What I would like to say that we have a panel here today, and I'm just going to quickly introduce them, or let them introduce themselves very quickly. And I'll start with Diane Hedges. Diane, would you like to just quickly introduce yourself?
Thank you, Ros. My name is Diane Hedges. I'm the Deputy Chief Executive at Oxfordshire Clinical Commissioning Group, so it's where the resources flow in, and then we support providers in delivering care.
Thank you, Diane. Dr. Ben Riley?
Hi there. My name is Dr. Ben Riley. I'm the Executive Managing Director for Primary Care, Community Services and Dentistry at Oxford Health Foundation Trust, which is the main NHS provider of community services in the county.
Thank you. Kirsty Blee? Kirsty.
Hello, I'm Kirsty Blee. I'm clinical lead of one of the ambulatory units, and we form the urgent and ambulatory provision across the community in Oxfordshire.
Thank you. And Tendai.
Hello there, my name is Tendai Mugariri. I am also clinical lead, one of the ambulatory care units in Oxford Health. I'm also an advanced nurse practitioner in Oxford Health. Thank you.
Thank you very much. So this evening we have a presentation that will take us through till about 10 to 7, at which point the questions that you can post during the presentation and after the presentation, we will do our best to answer them, and we will be definitely, I'm challenged with closing this meeting at 7:30. So I'd just like to hand over to Ben, who's now going to take us through the presentation.
Okay, thank you very much. I thought it'd be helpful to start today's discussion with some background about community services. And these are the services that are available to a wide range of people living, working or studying in Oxfordshire. And these services are provided in people's homes or in other community settings to support health and to provide care. And they form an essential link between GP practices, hospital care and local communities. And they often go under the radar largely, but provide quite a wide range of support for many thousands of patients each year, as well as their families and carers. So the sorts of services we're talking about include community nursing, therapy and a range of other support for people of all ages and backgrounds, all the way from the very young through to the elderly. And that includes services that keep older people more independent at home for longer, including social care and voluntary services, as well as the NHS services such as community nursing, therapy and reablement. Also includes the GP care available when your practice is closed in the evenings or weekends, and also services for people living with long-term health conditions. Next slide, please. So this is a map of Oxfordshire which shows our community hospital sites. Community services are at the centre of the population's health. So as well as the community hospitals, this is showing where our outpatient facilities in the community and our urgent and ambulatory care centres are located. And as care increasingly shifts into the community, we're expecting home-based services and community-based care to grow in the coming years. And particularly as we roll out a new requirement coming in across the country to respond to older people in their own homes within 2 hours of a health or a care crisis, which is part of the NHS's Ageing Well programme. During this pandemic, all of these services have played a major role in providing care for patients, providing urgent assessments, rehabilitation, expert nursing and therapy care, amongst other things, and that's all about helping older people to recover and return home as soon as possible. And I'm pleased that we're joined today by 2 of our senior clinicians from some of these services who can share some of their experiences with us. And despite enormous pressures on the workforce during the pandemic, we've managed to keep these services going nearly all of the time, which is a fantastic achievement for the teams. Next slide, please. So what will be covered by the community services strategy work? So as part of that work, we're reviewing a wide range of services with particular focus on those that support older people, including our urgent care services and our community hospital services. And as well as developing our ability to respond more effectively and provide more care in people's own homes, the focus at this stage is on older people, but we will also be taking forward work to develop children and young people services in parallel to the strategy work, recognising that there are challenges facing these services too. And all of that together is going to be absolutely critical to meet the needs of our most vulnerable families and people that live in the county. Thanks. So at this point, I'll hand over to Diane Hedges to talk a little bit about the principles lying behind the strategy.
Thank you, Ben. One of the things, just a reflection that clearly came with the very extraordinary last period we've been through with COVID, is how much we learned that we needed to work together if we were going to deliver the services and support people in their own communities, support people in their own homes, even when they weren't able to come out. And that's the kind of bedrock of us thinking now we have to go so much further with supporting people in their own homes. So you shouldn't be surprised to see that we've got such a wide range of partners involved in the thinking that we're doing here. So this is bringing together our county council colleagues, but also each of the district and city, along with the NHS providers, voluntary community side of things. So we really are recognising that in order to support people to live their longest, happiest lives in their own homes, this is a total partnership endeavour. So we've sort of set ourselves out there. We're looking at what priorities are for us to support people. And in so doing, we're conscious that we might need to change some things. And if we want to change things, what set of principles, what would drive our decision making in relation to that? How do you make choices? There's never enough of everything to go around. So how do we make how do we guide things? So that's the background for us wanting to say, what are the set of things, principles that will guide our decision going forward? And work that, so we'll all be working collaboratively. So I just want to quickly take you through the principles which you can find in the leaflets, and we're asking you to give us some feedback on. They're very much draft. They're here for discussion. So we've picked out a few examples where I want my clinical colleagues to help bring this to life. But hopefully, just as a high level, I can explain that we know we need to get a better experience for people seeking or receiving care in their own community. And we are also conscious, if you look at the Joint Strategic Needs Assessment, it tells us there's about 9 years difference in life expectancy across different parts of Oxfordshire. So there are differential ways in which people are accessing and experiencing our services. So one of the things we want to do, make sure it's a better experience and make sure we get it to the right people. That plays through in making sure there's equal opportunities for everyone across the county. So those differences in outcomes and inequalities I've referred to. One of the real drivers through everything we're doing is how we support people to be in their own homes. The best bed, your own bed. And I would like to ask Tendai to give us an example of where we've really shown how we can make a difference in supporting people in their own homes. I'm just going to briefly pass over to Tendai.
So I'm going to talk about a patient that we have seen in the community. He is an 80-year-old man who lives in a care home. I'm going to use the name John for confidential reason. So on this morning, the care home staff noticed that John was not himself. He has got a background of dementia, but he's usually potters around with his frame and enjoys life. He also had a written plan or an advanced care plan stating that he would prefer to be cared for at home if he becomes very unwell. So the GP practice visit John. They found him acutely unwell with a fever, and they referred him to the emergency multidisciplinary unit. So at that point, the decision was made by the senior doctor for an advanced nurse practitioner to visit him at home. On arrival, the nurse found John quite drowsy, needing to be hoisted, which was not normal for him. His examinations and clinical findings showed signs of significant infection. So he was immediately treated by the nurse with intravenous antibiotics, intravenous fluids, and paracetamol. Bloods were also taken on this day and they were sent to the John Ratcliffe lab. A special note was sent to out of hours department for them to be aware that there was somebody very unwell and the plan that had been put in place already during the day. On day 2, the lab results were reviewed by the EMU doctors, the emergency multidisciplinary doctors. They found that he had quite a severe infection. So they discussed him with hospital at home, another team again, which works in the community. And they requested them to go again and see him, give him some more IV antibiotics, fluids, and to check him how he was. So when this team went out, they found him sitting in his bed, still unwell, but he was able to watch TV. They gave him another dose of IV antibiotics and fluids. On day 3, they had another visit. Again, he had another visit again from hospital at home, and they found him sitting out now by his bedside. On this day, he was managing a little tea and a little porridge. He was given a further intravenous antibiotic and fluids. On day 4, again, hospital at home visited him, and John and the care home staff, they felt that he was on the mend. He was now eating and drinking better. The assessments on this day and examinations were indicating an improvement. So the antibiotics were changed to oral antibiotics and they stopped giving him some fluids. On day 5, hospital at home again, it was now a Sunday. They visited John in the day, and they found him in the day room with his brother. He's feeling much better and he's hoping to go out for the afternoon. He walks back to his bedroom to be examined and to have another blood taken from him. On day 6, he was discussed virtually on a virtual ward round with the emergency multidisciplinary doctor and the hospital at home team, and they decided to discharge him. The bloods were showing a significant improvement. He had 2 more days of oral antibiotics. John was at this point discharged from hospital at home and from EMU service back to GP care. So in summary, he had minimum 6-day hospital admission, which we prevented. Thank you.
Thank you very much, Tendai. So really powerful in terms of a service that we wouldn't have had before, that would have ended up in a hospital admission, and can be done so much more in a such more satisfying way for people and support at home. The other area that links on this slide is also the use of digital approaches. And I know during the COVID pandemic, for example, the giving out of pulse oximeters to patients so that GPs and others could monitor patients from a distance and keep people in their own home is only one example, but many other examples of how we need to use the digital support and technology around us to ensure that we give more care. To pass on to the next slide. So there are three sets of principles in terms of 3 slides, and this is the next 4 principles that we think are going to be important in making decisions. And one of the areas that really rings out for us is the joined up services. One of the things that was said to us in the older person strategy, telling the story only once, and certainly getting the care in a joined up way. So more services, that enables us to improve our effectiveness and quality, but I think will obviously also offer a better service. So less duplication for the client, but also we have one of the things that runs through our thinking on the community strategy is the challenges that we have on workforce, and obviously the way in which we can get people to work in a joined up way will support that. Ensuring our use of beds in the community maximises people's long-term health. That is clearly an ambition, that where we do use our beds, we'll only use our beds to offer treatment that can't be provided in other ways. And part of that is based on the evidence base that actually numbers of days in a bed are detrimental. They would create muscle wastage and other issues. And if I may, I'd like to get Kirsty to bring this to life with real case examples.
Thank you, Diane. So I'd like to talk about a case where we as a team in ambulatory care, we were referred a patient who I will call Jane, not her real name. She was an 84-year-old lady who her GP had received a call from her family member saying the patient was dizzy and unable to walk as they normally could. They'd had several falls over the previous couple of days. So the GP booked a community hospital bed for them, suspecting a urinary tract infection, suspecting they had a water infection. So we went out to assess them as a team. And so they usually lived independently. They were normally able to wash and dress themselves. The daughter did some of the shopping, and the lady, Jane, often took the taxi into town to go for a coffee with some friends. But she was now quite frightened to move about her home because she was dizzy and feeling awful. She had a history of swollen legs, a sore back, some bone wastage, and she often had an irregular heartbeat. So a nurse and a physio visited the patient. They completed the nursing assessments. They included sort of testing blood at the bedside, and they did an ECG, a bladder scan. They checked her memory using a cognitive assessment, and they checked her skin. And we started collecting the medications because we wanted to look at what medications the patient was on. So all in all, we discovered that the patient didn't have an infection at all, but had been taking strong painkillers, several at a time, trying to deal with the pain in her legs without realising quite how they worked. And she wasn't taking her other medication properly. She also had quite swollen legs, so she had a lot of trouble getting suitable footwear, which didn't help with her falling over. So we gave her some IV fluids, some fluids in a drip, and we started some different medication that would leave her less drowsy and enable her to gain her mobility. She chose to sleep in a reclining chair overnight so that she could use a commode that we brought with us directly next to it. She was really reluctant to go into a hospital bed. If it had been the absolutely right thing for her, I think she might have done it, but she was really reluctant to leave her own home. So we arranged for several therapists to assess her over the next few days, doing things like supporting her with a walking frame. They obviously provided the commode to reduce the amount of mobilising she would do to increase her safety at home. And we visited them daily to do observations and empty the commode and take bloods. And overall, we saved her about 3 nights in hospital just by doing that, because by day 4, she was back to her previous self, and walking and using the shower and arranging for taxis to go into town. So it really demonstrated that the sort of level of recovery that patients can have in their own environment, they often feel safer in their own environment. And she was not exposed unnecessarily to other infections that she might have picked up in hospital. She didn't have unnecessary treatment with antibiotics and things, which often are started straight away if you're worried about somebody with an infection. And it took a team of ambulatory unit nurses, paramedics, physiotherapists, occupational therapists, hospital at home team visited. So it demonstrated the value of very rapid comprehensive assessment and rehabilitation at home, because you can often see things which are missed in a hospital setting. It enables you to really tailor the plan to that individual's needs, how they live, what they do on a daily basis, how their environment's laid out, and support their wishes to not go into hospital. So she had a very positive outcome and very rapidly returned to her normal self. It was very effective and she was grateful.
Brilliant, Kirsty, thank you. And really powerful to see again what we can do with just that partnership working and people looking for how we can support people. You won't be surprised to see there's a principle here about how we operate effectively in teams, that we're using the right skills in the right resources in the right places. So, discussions, meetings I was in this morning, again, talking about where we can get enough physio support, where we can get this sort of nature of skill and that nature of skill. We need to know where we've got the resources, we're using them most effectively. And so how we operate in effective teams, whether it's in a bed base or in the community, how we make that the most effective use of the resources we've got. And most importantly, base the design of what we do on good clinical evidence. There's ensuring that the care we give can be shown to have a research base and evidence base, and it will make a difference rather than just feel right. It has to actually make the most impact. And some of the things that we're talking about here are the nature of the therapeutic input we need, means that we need to really take on board some of what the research will tell us. We move on to the next page. The theme that you'll hear running through what I'm talking about is how we ensure we've got that workforce, and clearly, and hopefully we'll hear more from Tendai and Kirsty, but we absolutely need to make working in Oxfordshire community to be the best place where people want to work. So therefore, we've got to be designing services and systems, care pathways that people feel brilliant delivering and feel good for the patients as well. Delivering the locally and nationally agreed priorities for our health and care system. So there is an awful lot of national must-dos and local things that we want to achieve. One of which is the provision of outpatients and making sure people get the diagnostics they need. Really pleased to say we've got an award-winning service in the cardiology services that are now being delivered with GP specialists in conjunction with our Oxford University Foundation Trust. So they've got the best of the best in the tertiary centre, supported by the best of the GPs doing cardiology clinics, and best of all, they're being delivered in local settings. So you don't compromise the quality you're getting, but you're getting that more locally through a rich skill mix, good education and support for the GPs. They know they've got all the backup of everything at the centre, but equally you can get that local access. So some really good ways in which we can use all the skills of everyone right through the system. So we must be delivering the national priorities. We must be doing the things that we need to do locally as well. So we can't compromise on those expectations on us as an NHS. We need to contribute to sustainability and environment. We've heard so much about climate change. We know how much, some of the footfalls that we see in our NHS services are incredible, and whether we can get some of that patient activity to be done more locally, or if we can use the digital solutions, not have people travelling at all. And then the last one here is about the use of our resources. So we want to make sure that we maximise the health and well-being of our population. That does mean we'll need to make choices within resources that we have. So it's maximising, but using the resources as best we can to deliver best benefit. We move on to the next slide. So those are the 12 principles that we want to apply to thinking about those services. Ben's laid out a range of services that we're thinking about the scope of. Are we doing it as well as we should? Is there another way we should be doing things? They aren't set in stone. They're here to talk about, they're here to ask questions about, and we're asking survey responses from you about them. We're running tonight. Obviously, we've got a few more events planned already into the diary, and if there are other significant events that people have got that you'd like us to join or be participants of, we'd be really keen to do. So we really want you to reflect on what you've heard today, ask us questions about it, and share your views, and we will use your feedback to think about whether we've missed anything, or is it the wrong angle, all of those aspects. So I think that brings to the end of myself, and I'm going to pass back to Ros.
Thank you very much, Diane and Ben and everyone really. And thank you for those in the audience who are flying in the questions. I hope that this session has helped explain why these principles are important and what they mean. That's the aim of it. And we now obviously have an opportunity to answer any questions that you have. And do keep posting them in comments, and we will respond. So I'm going to take them in order of appearance, if that's okay. And I'm going to do my best to get the right person on the panel to answer the questions, but I'm sure there will be a sharing of duties. First of all, the first question is, it sounds like an incredible service. So this is directed at Tahina, when you were talking about your story, your experience. And does it operate 24 hours a day? And how long would this type of service support patients like John for? And there's a linked question to that. And how does this service link to GP patients, to the patient's GP? So if perhaps you'd like to take that. We're going to fight over it. Great, thanks.
Thank you. So normally for our service, which is emergency multidisciplinary unit, our referrals, they originate from the GP. So for John, he was referred by GP. So we do work quite closely with the GPs on that score. And then we have got advanced nurse practitioners who are now in Raku Hospital at Home. We've got newly qualified ones in Abingdon, and we've got 2 in Whitney EMU. So if there is an outreach, so then advanced nurse practitioner is the one who goes and do the first assessments, like I explained, and treat there quickly. And then afterwards, there's another team which is called Hospital at Home. And then they will refer to Hospital at Home, who can then go and see the patient on a daily basis. It's not a 24-hour service as for John, but I understand, Kirsty may help me there. I understand Hospital at Home 24 hours when it comes to palliative patients, but yeah, they finish at 10 p.m. Is that correct, Kirsty?
Yeah, so in terms of the ambulatory service that we provide across Oxfordshire, we tend to be open up until 6 p.m. for RACU or 8 p.m. for the other ambulatory units, but we do provide this care, you know, to everybody in our localities that needs it. In terms of the question where it says, does it operate 24 hours a day? Well, that might be an ambition. You know, if this is a valuable service to people, then that would potentially be something that we would look at. Certainly extending services, but the next question down feeds into that a little bit in terms about linking in with the GP, linking in with other services, and you know, making sure we see the sort of acute patients at the right time, because it's all about priority a lot of the time, and joining up with other services. So it's not just GPs that refer to us. Sometimes a 999 ambulance will go out to a patient and they'll realise that actually they don't necessarily need to go into hospital. They could receive the kind of care they need from us. So they're diverted away from the front of the emergency department to us. Often it's district nurses who've noticed a patient is deteriorating, that they see all day, every day, you know, and they realise there's a change or something's different. So lots of health professionals do refer to us, but we always feed back to the GP. They get a comprehensive set of bloods, you know, any of the details of the work that we've done with the patient, any of the planning, it goes to them. And we also, as Tendai's already mentioned, we link in with out of hours, so that out of hours are aware of what we've done and if we're seeing them again, because that again contributes to that, how they manage a patient who might call them overnight for help.
Thank you very
Does
much.
that answer it?
I think it does. Thank you very much. The next question is about digital interventions, and the question is, how will you measure the effectiveness of digital interventions that do not seem appealing to some? I'm going to pass that on to Ben.
Thank you. It's a good question, and I think it's very topical, isn't it, this week with all the stuff in the press at the moment around GP consultations and so on. So there's a number of ways that you need to think about this, I think. So the most important one, in a way, is the patient experience of it and tracking that. So we need to capture that feedback, really. And in fact, digital technology often allows you to do that, you know, relatively easily by sort of getting feedback straight away on the consultation that people have just had. And we also need to be tracking the sort of effectiveness of it and the safety of it in terms of the outcomes. And so that means tracking whether people end up, you know, having a digital consultation, but then end up with a face-to-face one or an A&E attendance or an admission after that. So we need to be able to look at that. And then there's also critically looking at the people that aren't using the digital technology and making sure that we're not inadvertently making, you know, it more difficult for people to access care if they're in a more, you know, vulnerable group, for example. And I know, for example, Age UK are doing a lot of work around supporting older people to, you know, learn how to use iPads and so on, and access equipment for digital consultations at the moment. But so all of that is an intense area of research, because the amount of digital consulting has really gone up since the COVID pandemic started, really quite dramatically. And I know the University of Oxford, for example, is doing a big project with our trust at the moment, looking at the effectiveness of mental health consultations. And so we'd be learning from that to sort of, you know, see if they are safe and effective compared to face-to-face consultations. So it's like one of these, I think it's like, it should be thought of like a tool in the toolbox that we have, not a answer to everything. And there will always be a need for face-to-face consultations and visits, just as there will for digital, but because digital consultations can improve access to groups of people, and some groups actually find them a lot easier to use, and, you know, some of the teenagers like them, especially in our children and young people services, for example. So it is an area that we're looking at, and we will be, you know, evaluating it.
Thank you. So I think what you're saying there in answer to that question is that there is constant evaluation and development done, including listening to patients' experiences of that. So we have some assurance that you don't just set out digital on the digital road and not check to see how it is for
yeah, absolutely.
Okay,
yeah.
Thank you. I think next question I'm going to go to at the moment is related to very much this working together, and how will the services in the community support more people when there are fewer staff? Connected, and the other question that came in that was similar to that was, how will this work in terms of staffing? Surely having people in one place getting care is easier to manage than teams of nurses going here, there and everywhere. Would you like to kick off on that one, Ben?
Sure. So I think it's true to say that staffing is a significant challenge for the NHS as it is for wider sort of area sectors, as we're seeing at the moment again this week with HGV drivers, for example. But we do know that staffing is a real challenge, and it's absolutely critical because you know, the NHS is and health and care services more broadly are people businesses, if you like, and completely reliant on having caring and well trained and skillful staff. So we're very, very conscious of that, and workforce planning is going to be a core part of this strategy. Part of this, though, is about making our jobs more attractive for staff, and in order to you know, recruit and retain people and train them and give them a career path so that they stay with us throughout their whole working lives, ideally. And that's why developing the services in this way is really important, because we need to keep modernising and reflecting the fact that you know, the world is changing around us and the needs are changing. We've just talked about digital technology. That's one way that you can expand what you can do to some extent with workforce restrictions, but we do, you know, recognise there's limits on how far you can go with that as well. So I think it is absolutely a priority as part of the strategy. Just in terms of the point about is it easier to have everyone in one place and manage it there than having people going everywhere? Well, that may actually be true, but that doesn't mean it's the right thing to do for patients, or that it would lead to the best outcomes, because we do need services to be accessible, and there is strong evidence now that care in people's own homes is often preferred by people and leads to better outcomes for large groups of older people in particular. In fact, I might bring Kirsty in this time, if you like, to talk a little bit about that experience of how do you manage a team that does get called across, you know, multiple areas.
Yeah, it's a challenge, but it's also one that the team usually rise up to. So some of the ways that we've managed things has incorporated a little bit of digital, a little snifter of people flexing their roles. And for example, we might not always have an advanced nurse practitioner to send out to a patient who's deteriorating. However, we have got very skilled paramedics, or we have got very skilled nurses who are skilled in doing various types of assessment, whether it be abdo. So they will go out and they will do an awful lot of things to assess that patient, and then they will use digital technology to liaise with either the doctor or the AMP, me, or a therapist if it's most appropriate, that they've discovered that actually it's not a significant clinical issue, but it does require some therapy input. So we are in a position where we can actually do remote prescribing, and you know, they will go out already prepared. We take stuff out in our bags when we go out as AMPs or as clinicians going out to see a patient. For lots of different eventualities, we're trying to do as much high-level assessment and intervention for that patient as early as possible to prevent them having to go into a hospital situation. Because particularly with our older, frailer patients, it doesn't always take an awful lot. You know, when you're managing a balance of different conditions, some of them that are opposite to each other. So you could have someone who's very dehydrated but has all their fluid in their ankles because they've got a heart failure. So it's managing all of those things and having people who are experienced and clinically able and dynamic to be able to do that. And that's what we've been doing. So we have had less resource because, like everywhere else, we've had people off sick, people isolating, etc. But we've got really dynamic staff, and we're investing in them. So the trust is training people up all the time to be, you know, what they want to be, which is more advanced clinicians. They can assess, they can see more, they can do more at first point of intervention. So that's how we've managed thus far.
Thank you. I think there's another question that follows on from that, and it's is in what way will you improve communication between services to ensure a joined up approach? And I think I'm guessing that this is not just between services within, it's all services that patients might need. So it's across health, care, exactly, whatever. How are you going to improve communication to ensure joined up care? Ben, do you want to go with this first? You're mute, Ben. Yeah, I got to say it.
Sorry, it's going to happen sooner or later, wasn't it?
It was.
But yes, I'm happy to kick off with that one, and then Diane may wish to comment too from a commissioner point of view, because system working is increasingly something that we're engaged in doing, and I think it's recognised now that there are very few areas of health and care where it's just one provider providing the services now, and people are often looked after by multiple providers. So the way that we actually approach it is by setting up various sort of structures, if you like, for how we do that. So we create groups of multidisciplinary teams at different levels in the system to care for patients and communicate. So that can happen at a primary care network level, for example. So that's a sort of cluster of local general practices working with their local community teams, and often with input from the acute hospital. In fact, we're running a couple of pilots, such as one in Bicester at the moment, looking at how that can work. And sort of wrapping all those different services around patients and making sure we're working in the most efficient way. And then we also do it at a sort of larger system level every day. In fact, people may not be aware of this, but every day sort of starts off with various sort of huddles or system meetings where we share the sort of situation in our services and talk through challenges that we're trying to get patients home, for example, from hospital, and things that are blocking that, and work through it that way. So there's a lot of that work going on behind the scenes already that we'd build on. Dan, I don't know if you'd like to come in, and because the CCG plays quite a key role, doesn't it, in facilitating some of that?
Yeah, I think, and I'll weave in one of the points that somebody else has made in the question about the nature of contracts, and we used to have a historical model where it was a cost per case, so every episode that we were buying from the John Radcliffe from the hospital would be paid for on a price, and the more activity you did, the more money flew. And actually it didn't necessarily bring us together in the way the question is actually saying we need to be. People all need to be kind of working with that limited resource that we've got and make the best of it. So actually I like to think now that the contracts are put to one side, and it's all about the collaboration and how we bring people together, which is what Ben's been describing in the sort of daily meetings. So the resources that we have, we need to use better. We do obviously use contracts in some instance, and I absolutely was there leading the charge around the workforce challenges we've got. But what I don't want people to leave this meeting thinking is that we've got less workforce. We're actually recruiting more and more workforce. It's just that there's more and more demand to go with that workforce. So we've got quite a good blending of role that's now starting to happen. So you'll see a whole range of different sorts of practitioners now working out from your general practice, whether they've got skills in mental health or skills in physiotherapy, skills in medicine or prescribing, the use of your drugs and pills. So there's a sort of blended workforce there. We're doing much more with social care, and social care are trying to break the challenge that we've consistently had in Oxfordshire to a great extent, which is us being able to get enough support workers and care workers and reablement workers to support people in their own homes. So we are buying more and more care, but making sure that care is offered in a much more joined up way, and increasingly trying to blend our flows of money together so that it doesn't feel like the people who hold the purse strings are just working with that organisation and that organisation and that. We're kind of trying to make it all be one flow of money. How well does it work? And the resources that we've got, the money and the workforce, most importantly, are being found in all sorts of ways. And that's, again, the partnership that we are doing with the local councils, whether it's city and district. They've managed to help us get to all sorts of places that we've never been able to get to before. So trying to address the inequalities, being able to knock on people's doors and say, how can we help you get your vaccination, etc. So all of that is about us trying to work more smartly together as public services. We have lost
Thanks,
Ros.
Diane. I think we've briefly lost our chair, so I think Ros might be having some technical difficulties. So hopefully she's trying to dial back in again. now. I don't know whether you're looking at the questions in the stream there, but I did wonder whether the one from Anonymous that refers to OUH in the way that it supports pathways as mission avoidance. It says, what extent does OH and the CCG hold OUH to account to ensure they're exploring all options? Can you see that question? I don't know, Diane, whether that kind of links a bit to the contracts.
Yes, that was the one I was trying to weave in that actually things don't work the same as they used to now. So actually we have only got one pot of money in the whole of Oxfordshire, Berkshire, the Berkshire, Oxfordshire, Buckinghamshire CCGs are coming together, and we've got in effect one pot of money to go across all of our different NHS providers. So I think, yes, we are, as our relationships have built and grown through COVID, we are holding each other to account much more robustly. In fact, Ben and I have just come from a place discussion with senior leaders, very much holding each other to account around making sure we're making the right choices about staff and about money and about priorities.
Thanks, Diane. Just scrolling down to the questions. I'm sorry, I wasn't quite prepared to be taking this role, but there's a question further on down that refers to staff, and it says, how are staff coping with increased demands? Everywhere we go, we hear that everyone is exhausted. Same with teachers. What's being done to support staff? Is that something, Ben, I don't know whether you might be able to start with that one?
Sure, and it's a really important question, really. So it's absolutely true. People have been through a very, very challenging 18 months with COVID, having come out of a winter before that where people were still pretty tired, I think, before. So we've certainly, so as the trust is concerned, we've got a programme of welfare support for staff. We've put in place a range of different measures. That includes giving people sort of extra a day of leave as a reward. That's not much, but it's a little contribution, but also encouraging people to sort of take their leave, and because we did have a bit of an issue at one point with people just working so hard and feeling that they couldn't really step away. But also welfare support as well. For example, we've taken on extra psychological support in our occupational health services and things like that, and we have people we employ to actually run welfare sort of program for the staff as well. I think there's also something about recognising all the huge contribution people have made. We've been looking at how we reward staff and activities that we also do collectively to keep morale up. So we have a range of sort of team things, like we had a Teams sort of virtual choir, for example, and other sort of exercise related things that staff get involved with. So this is all sorts of ways of trying to keep the team going and keep morale up. We're also looking at the workload pressures as well, and as people leading and managing the services, it's our responsibility to sort of keep on top of that as much as we can, recognising that we are in a very challenging time where demand's going up as well. So yeah, we're sort of looking at that as best we can, and as I mentioned, that addressing things like where we do have vacancies and recruitment sort of gaps, that's another part of it.
Thanks, Ben. I'm just looking at another question that's on a different issue, but Diane, there's a very specific one about end of life and palliative care in relation to the service actually says Tilehurst, but I think it's also referring to South Oxfordshire with the Nettlebed service. So do you want to just give a update on the provision there?
Yes, so we obviously did lose the Sue Ryder Hospice in Nettlebed because Sue Ryder needed to take the decision to close that. So we have been exploring with colleagues in Oxford Health and also Sue Ryder the provision of some specialist palliative care beds in Wallingford Hospital for the south of Oxfordshire. Which we are hoping will be opening by the end of the calendar year, if not before. I know I get constant debate about whether 2 beds will be sufficient, but we have said that can be flexed up if we do find there is additional demand for that. And obviously we're hoping to, we're working with Soho House and Duchess of Kent for making sure that those beds do continue to have new admissions within them. I'm also aware that exploration is being made about other models to support the care in people's own homes for specialist care as well. But yes, we are absolutely making provision for when people do need to have an inpatient hospital episode, and we do keep checking carefully with the local GPs as to whether they have got experience of patients who they felt really needed a bed and weren't able to access it. So Dr. Ed Capobianco, who works with in the CCG, is very close to the GPs in terms of making sure that we are aware if there are any instances where people might not be able to access the care they need, and we haven't been made aware of any of those recently.
Thanks, Diane. It still looks like Ros is clearly having some problems because she's not reappeared on the meeting. There is another question that's come through just recently, which I think is referring to the project as a whole, but saying how is this all going to work when the CCG won't exist come April, which I think, Diane, I'm afraid I'm going to have to come back to you again, I think.
Yeah, so the CCG will simply be blending with the other two CCGs in Berkshire West and in Buckinghamshire. So the staff working in the CCG will all be brought into one larger planning organisation, and we're very much clear that the way in which we work, which is to call it place, so Oxfordshire is a place. In the way it's defined, as is Berkshire West and Buckinghamshire. So we're very clear that the majority of the work that we do will continue to be very much accountable to Oxfordshire, facing into the Oxfordshire Scrutiny Committee alongside Oxfordshire County Council. So we will continue to be very present in Oxfordshire. What we would also hope to do is that we can pick the best of the learning across our wider landscape. So make sure that if they've done it brilliantly in Berkshire West, we learn from them. If they've done something brilliantly in Buckinghamshire, we learn from them, but very much can make the assurance that we will be very visible and expecting to have a location planning in Oxfordshire. We've got very robust arrangements with our local council, which are all about the sort of future proofing and making sure that this is an Oxfordshire lens that's looked through as well.
Thank you, Diane. It looks like we've just heard that Ros has suffered a power cut at home, which is the reason that she's clearly not able to come back and join us this evening. So if you're happy, I'll just keep going and for the last sort of 5 minutes. It doesn't look like we've got any fresh topics in the question bar, so I wonder if we might just use the last 5 minutes of the meeting if members of the panel have anything extra that they would like to perhaps add that our audience might be interested in before we close. Ben, can I start with you if you've got any other words you want to share with our listeners today?
Thank you very much. Yeah. I've had a little bit more time now to think about the questions about the staff employment. So one thing I should have mentioned actually was we've actually launched a sort of mental health support hub for health and social care staff. So if people are having difficulties, then they can contact that for extra support as well. And that's in addition to our employee assistance programs. And we also recently did a sort of month of wellbeing activities called Health Fest as well. So that's just a little bit of extra information there. But I suppose I would just think about encourage people to contribute their thoughts around the principles. Really, we've had a really interesting discussion this evening covering many of those principles. But if people do have any additional thoughts or do please let us know, because this is a sort of work in progress and we're keen to hear from everyone.
Thanks, Ben. Diane?
I was just going to pick out a couple of points that we might not have touched on as much in the questions. So there was a question about inequalities, which we did make reference to, and then question linked to Wantage about services already being strained because of staffing challenges. And I guess I want to link those things back to our principles. So that's the kind of things we're asking. We're saying we do need to recognise the workforce challenges, and do we therefore need to think about how we set teams up so that they are resilient, that they can make sure that they do not have gaps in services, that we embrace the broadest use of working with the voluntary sector, working with skill mix, and working into each of the settings. So I think it drives to the heart of we do believe there are some things we might need to change. We might need to kind of focus further and harder into addressing some of the inequalities, knowing which wards, knowing which sorts of communities can have less good outcomes than others. Do we focus our efforts there? Do we spread all of our efforts everywhere and then find we've got insufficient workforce? So I'm just trying to be slight and not trying to be controversial, but just trying to sort of play back that the point of the principles is to help us make some of these choices and differences. It is brilliant and amazing that more people are living longer, but they're living longer with more and more conditions, and the NHS and the rest of our public sector services have got to respond to that. So how do we do that? How do we focus and do that to our best effect? And if there are ways in which people can think around, from our perspective, how we might help you stay in your own homes that we're missing the point on, and clearly something like digital can be a clear one where we may, not be understanding what it feels like. We need, those are the things we need to hear and understand. Thank you.
Thanks, Diane. We're literally right at the end of the meeting. Kirsty and Tendai, I can see you on my screen, so put your hand up if you have anything that you would like to say. Oh, okay, Kirsty, brilliant, thank you. Just wait a minute and I'll just change the screens over before we finish. Thank you.
Thank you. Yeah, the last point I really wanted to make sort of does refer in some way to the hospice provision. In the south, when Sue Ryder closed Nettlebed, they did open the hospice at home hub. So we're linking with them very, very frequently to support patients at home in that respect when they might need our help with certain symptoms or with certain interventions. So the key, I think, is really the joining up of all of our services, whether it be the voluntary sector, whether it be the acute, whether it be a whole multitude of community services, because then you will reduce the provision and requirement for beds if we're all joined up doing our best and our bits together, because the wraparound service for the patient and the person in their own home should be enough.
Thanks, Kirsty. Thank you. So, Tendai, sorry, I didn't see your hand go up, so I'm assuming you're. Oh, you do? Okay, sorry. Hold on a moment. It's a little bit clunky moving everyone around, but there we go.
Yeah, so I just wanted to add a little bit that I left out about feedback that we are getting from our patients when we treat them at home or closer to home. It's been really brilliant. And it's quite satisfying for nurses out there to go out and look after patients in their own homes. And I don't know, I just want to encourage people that it's actually really a good service that is coming up, and especially for our frail patients, and they really love it. We did send a few of our feedback to our CCG just to show them how much our patients are appreciating what we are doing, rather than sending them unnecessary to the acute when we can actually do much more in near home or in their homes. Thank you.
Thank you, Tendai. If Ros was still in the chair here, I know how she would be ending this meeting by thanking you all very much for taking the time to talk us through that presentation. And thank you to everyone who's been listening in and putting your questions in the comments, which has been really helpful because we can then get a sense of the sorts of areas that people are interested in or that we perhaps haven't explained well enough. So I think what we're asking people to do now is if you would like to reflect on what you've heard this evening, that you might take a few minutes to go and complete the survey. Emily did earlier in this evening put a link to the survey in the comments section, the questions section. If you scroll back up, I think she put it in about 6:32. If you can't find it there, you'll find it on the OCCG website. And the survey has only got 4 questions, so it won't take you long to complete, but we'd really welcome your feedback there. It's open until the 10th of October. If you want to participate again, we've got 2 more of these meetings and you're very welcome to join again. But for now, we're going to end the meeting. Thank you.